The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Thank you for attending today's webinar on protocols for addressing sheltered and unsheltered homelessness during the coronavirus pandemic. I'm Mindy Mitchell, Senior Technical Assistant Specialist here at the National Alliance to End Homelessness. We have an important webinar for you today led by Cynthia Nagendra, Executive Director at the Benioff Homelessness and Housing Initiative of the University of California, San Francisco. Also presenting will be Dr. Margot Kuchel, Director of the Benioff Initiative and the Center for Vulnerable Populations at UCSF, and Vivian Wong, COO at Abode Services in the Bay Area. I know everyone is struggling right now in this time of unprecedented crisis, and we hope that the Alliance's COVID-19 webinar series can be a resource for you in the incredible work you all are doing right now to continue to serve our most vulnerable populations who are at such great risk during this pandemic. To that end, before we get to the webinar today, I just wanted to let those of you who were on or tried to get on yesterday's first webinar that there was actually such demand for the webinar that the webinar platform was unable to accommodate all registrants. This in turn led to some audio difficulties on our end, for which we apologize. Because of the overwhelming demand on registration for upcoming COVID-19 webinars, after today's webinar, the Alliance will be shifting to a different webinar platform that will accommodate many more users and ensure that everyone is able to access our COVID-19 webinar content in real time. If you have already registered for an upcoming webinar, your registration has already been transferred to the new platform, which is Zoom, by the way, which will require a different link for you to access the webinar. We will be resending confirmation emails shortly to ensure that all previous registrants have access to the new webinar links, and you must join the new webinars from those new links, which will be sent to you via email. So please be on the lookout for a confirmation email from Zoom with the new webinar link. You may need to check your spam folder to ensure that you receive those emails. Finally, a quick housekeeping note. All participants will be muted except for speakers and panelists during presentations, but we encourage you to post questions in the chat box. The director of our Center for Capacity Building, Christy Schulenberg, will be fielding all your questions and make sure that as many as possible are addressed by our speakers during the Q&A portion of the webinar. Finally, we will also post the webinar recording, slides, and a one-pager with key takeaways for you on our website as early as tomorrow. And in the meantime, you have 2 handouts available in the GoToWebinar chat box that our speakers today will be referencing. Okay, now we're going to get started with Cynthia Nagendra.
Hi, everybody. Good afternoon to everyone across the country. I am Cynthia Nagendra. Thank you for the nice introduction from the Alliance, and thank you for inviting us to be on this webinar. We have a lot of information to cover today, so I'm going to get right into what our agenda is. Next slide, please, Mindy. Wendy, Mindy, I'm not seeing the slides advancing, so I just want, maybe it's just my computer. I want to make sure that they're advancing.
I'm showing it on my end as UCSF Benioff Homelessness and Housing Initiative.
Okay, it must just not be advancing on my end. Okay.
Cynthia, it's not advancing on my end either.
Okay, so we're not seeing the slides advance, Mindy. I'm not sure if that's a delay or... I can just jump into the agenda, and then, you know, once you perhaps get the slides to catch up, then we can try to match them up. But I can just talk for now on about today's agenda. So today's webinar is as I said, covering a lot of information. There we go. I see the slides now. Thank you. So we are, this whole series is about COVID-19 and homelessness. And today we are going to be talking about some specific protocols that were developed for the state of California that we're hoping other communities will be able to draw from and adapt in the ways that make the most sense for their communities. I'm going to speak a little bit just about the kind of current situation on the ground, the potential impacts on homelessness and the homeless system capacity that you are all probably very familiar with. But for folks who may be joining that are trying to learn about homelessness and COVID-19, just want to talk a little bit about that. We'll be talking spending most of the webinar on recommended protocols for COVID-19 responses for individuals experiencing homelessness. And these protocols were developed in partnership with the state of California, a state team of experts in homelessness and health, state agencies, and CDC guidance, and Dr. Margot Kuchel, who will be speaking on the webinar today, and the Benioff Homelessness and Housing Initiative, which we will tell you a little about in just a minute. We'll be focusing on the critical elements of the recommended protocols, as well as the screening and referral protocols for sheltered staff and folks working with unsheltered people. What I really want to emphasize is that the two documents that are in the collateral section of in the handout section of your webinar, which are both the written protocols and a flowchart that visualizes the protocols, have the full details of what we're going to be talking today. So I encourage you to download those from the webinar and really refer to those because they will have the most detail. But we can certainly contextualize them and kind of walk you through them in as detailed as we can in this time. We will also we're very grateful to have a wonderful provider, Abode Services, who serves 5 counties in the Bay Area here, who are going to, and Vivian Wong, the Chief Operating Officer, is going to be talking specifically about standing up emergency hotel capacity and adapting existing shelters. They do a wide range of other things at Abode, but they're going to be focusing on that particular aspect. So I think that will really kind of bring some of these protocols to life as she talks about standing those things up. So just a quick word about what UCSF's doing. The UCSF Benioff Homelessness and Housing Initiative, or BHHI as we refer to it, is a new research and policy center that's focused entirely on homelessness, health, and housing. And BHHI, just launching now, is conducting rigorous and policy-oriented research. We really want to make sure that all of the research we're doing is really responsive to what's happening on the ground, to what policy really needs in terms of information to scale up interventions that work and make systems much more effective and sustainable in responding to preventing and ending homelessness. And we want to do that by translating evidence into action, informing effective, scalable homelessness and housing policies, innovative strategies, and realistic solutions to prevent and end homelessness in the San Francisco Bay Area, California, and across the US. We really hope that any of the work that we do really is able to kind of lend itself to adding value to the whole field. Our ultimate purpose is to aid in the creation of healthier communities for everyone through research, policy, community, and education. And we will be sort of developing more information about who we are and what we are in the coming months. So I'm going to start with the potential impact on homelessness and homeless system capacity. This is going to be something you're very familiar with for most of you that are frontline providers right now. So I want to just sort of touch on these really quickly, but for those folks who are funders or on the webinar to learn more about what's happening in homelessness, this is sort of just to give you a little bit of the landscape. I want to also say that this really came from a number, this information is coming from a number of sources that we're really grateful to. Providers on the ground here in California and across the country. The Alliance has done a survey. I know that they have hundreds of responses from people all over the country, kind of just talking about what they're seeing, what their needs are, and kind of how they're responding to this incredibly difficult challenge. So I want to talk a little bit about the pandemic as it's sort of playing out now. We know that homelessness has always been a public health crisis, and one that is becoming more severe and more apparent as a result of the COVID-19 pandemic. The COVID-19 pandemic is really creating a severe and emergent health crisis for the homeless population across the United States. And it's a crisis that our homeless and health systems we know are not adequately prepared to meet, and we're doing our best to try to meet the needs of people who are in crisis, but we know that we have a long way to go in most communities. I wanted to just point out that in new research, recent models of potential scenarios of COVID-19 severity, hospitalization, and fatality among homeless populations, homeless individuals infected by COVID-19 are modeled to be twice as likely to be hospitalized, 2 to 4 times as likely to require critical care, and 2 to 3 times as likely to die than in the general population. Again, these are just models based on certain methodologies. You can look more at the source material. The source there is at the bottom of your slide, and it is posted on the Alliance website, and it is authored recently by Dennis Culhane and his colleagues. So as communities across the country are grappling with the spread of COVID-19, people experiencing homelessness in shelters and in unsheltered locations face serious threats where the virus is spreading through their communities. Those experiencing homelessness have higher rates of acute primary health needs, including respiratory disease, and homeless individuals can be at much greater risk of infection and complications from infection. These issues, as many of us know, are particularly acute for seniors experiencing homelessness. And homeless shelters present additional challenges for people given the very close sleeping quarters and most often communal areas. So some of the challenges, as many of you were already providing shelter operations, the significant challenge that you have, and these are just a few, there's close sleeping quarters, communal meals, shared bathroom and laundry facilities, limited hours of operation, meaning people have to leave during the day, often because of a lack of staffing and funding to run the shelter 24/7. We're really encouraging people to try to keep their shelters open 24 hours a day and keep people safe and inside. Depletion of supplies and an incredible, just as everyone else is trying to get supplies that are needed for really keeping the area clean and sanitized. It's much more difficult in some ways for shelters to do that. There's a lack of training for folks around cleaning, infectious disease sanitization, and health screenings. So these are all very real needs that people need right now. So it's a continuing growing issue amongst frontline providers. I want to talk particularly about the vulnerabilities of people who are unsheltered. Later, Margot will address how to prioritize people for the safest locations possible and sort of what the thinking that goes into that should be. But I wanted to note here that unsheltered people are already vulnerable to the harsh effects of living outside, even without this virus, and face particular challenges in this context of COVID-19. And so while the CDC has provided some guidance about not sweeping encampments, it would be helpful to have better guidance on providing safety to people living outside, and we really would like to see more of that. In most communities, the majority of unsheltered people are not staying in encampment settings. They're often on their own or in smaller groups. And so communities really benefit from more guidance for how they should be trying to protect the health and well-being of these folks, and therefore better protect their communities as a whole and better flatten the curve of infections and illness. And so I want to remind folks that when we're talking about people living in unsheltered settings, we're really talking about a whole different, different groups of people living on the street by themselves, people living in various sized encampments, people living in places that are not visible or reachable by outreach workers or healthcare workers. And those are the folks we're obviously always the most worried about, especially as our outreach capacity gets more and more diminished. People who are often sleeping in close quarters in these areas. So even though, the CDC said you don't have to sweep in camps, it just means that, if there's nothing else available, if we have no other choice, yes, we don't want to disperse people and have them moving around, but we also want to think about their safety needs within those locations and try to provide what we can, because they have a lack of access to basic safety necessities like space, soap and water, for hand washing, that can prevent the spread of illness. And they really, people in housing, in shelter, in unsheltered locations all have a really significant reduced or total loss of access to food because of community-wide stay-at-home restrictions. Food banks, meal programs, a lot of those have been closed or decimated and are just struggling to kind of make sure that people are getting food delivered. So as challenging as this is, communities are creating more emergency capacity to provide safer options to prevent the spread of the infection in incredible and creative ways. That's just starting to ramp up. And Vivian Wong from Abode Services in the Bay Area is going to talk more about the staffing and operational and service considerations, because it does take quite a lot to stand this up and a lot of thinking that needs to go into that. So we're really lucky to hear from someone who's thought through many of the scenarios. The ideal scenario, of course, is that we have private accommodations for as many people as possible to dramatically reduce the likely transmission of disease. And many communities are beginning to scale up the use of hotels and motels and creatively using more individual spaces. And with hotels, you sort of have the advantage of already existing units. They have availability for ones because they're not being used and they are often empty. So often they are being cheaper. You can sort of negotiate. We're seeing people being able to negotiate with hotels for prices, for master leases, to even buy hotels. This might be a good way to sort of find naturally occurring affordable housing in your community for the first time for many communities. And it also generates revenue for them and helps keep their folks working. A less ideal scenario is bringing on new congregate settings, though we know that sometimes that may be the best choice you have available to you. It's just that those are often costly, slow to ramp up, and also difficult to operate in sites. So it's just something to consider when you're thinking about expanding your capacity. And again, just really quickly, I think this is something that you already are experiencing very deeply. We know we've been hearing from providers all over the country about the significantly diminished capacity that you're operating under. You're working with unbelievable challenges as frontline providers, facing so many issues, and even just the impacts on your own daily staffing and operations in all of these areas. Funding, staffing, operations, outreach, volunteers are no longer able to come in, the resources you need, and all these other sort of very vital things that you need to operate. We know that that is an environment that you are currently trying to operate in. So to emphasize something you all really well know, you are operating in these incredibly challenging circumstances. We know that you're in intense levels of crisis and heroically navigating and problem solving significant challenges. We've just been amazed to hear how you're doing that to your, it's challenges to your ability to even do your existing work and expand your capacity in all of these unimaginable ways. So I want to set some context for the recommendations we're going to talk about today. We know that you're operating in these circumstances, so the protocols recommended today are made in the context of evolving information and guidance with the understanding that your systems and providers are greatly compromised. We want you to really, we know you can't we don't want perfect to be the enemy of the good. You have to implement what you were able to with the available resources you have as your community tries to adapt to the very challenging and quickly changing environment. We hope these guidelines will help you to direct federal, state, local, and philanthropy and private sector resources to what is most urgently needed to help you advocate as best you can to implement these guidelines, and coordinate with health departments and systems as best you can. We know that is also very challenging from community to community. It really depends, as they're also very slammed and underwater. And so we know that that's a challenge as well, but we'll talk kind of a little bit more about how that's sort of an ideal situation is to be as coordinated with your health departments and systems as you can. The Alliance and some of their partners have put up recommended action steps, and I just left the link there because some of those action steps and considerations are really quite helpful in thinking through what you need to be sort of adapting all across your community. And in short, I just want to say that really all want to thank you. You're superheroes in this, and you always have been. We remain in awe of the work that you've always been doing, but now more than ever, your commitment, your perseverance is inspiring and it's humbling. And you're on the front lines during this crisis, and we're so grateful for you and your staff and your partners doing what you were doing for our communities each and every day. And with that, I'm going to turn it over to my wonderful colleague, Dr. Margot Kuchel, who is one of the main authors of these protocols, to set the context for how they came together.
Hi, thank you so much, Cynthia, and thank you all for tuning in. I'm Margot Kuchel, and next slide, please. We're just going to talk first about some of the principles that we developed when we were thinking about these protocols. Our really guiding principles were, our goal was to save lives, to protect people who are experiencing homelessness from becoming infected with COVID-19, and to use resources as well to reduce hospitalizations and therefore flatten the curve or the stress on the healthcare system, which really runs a risk of becoming overwhelmed and unable to care. Next slide. In order to reduce illness, hospitalization, and mortality, we really need to prioritize the highest degree of protection spaces, or those of private spaces, meaning like a hotel room with its own bathroom, for those who have symptoms suggesting infection, those who have the infection, and those with the highest risk of severe complications were they to become infected. To do that, we need to enact screening to have the ability to separate people who may be infected from others in congregate settings, whether that is encampments or shelters, to use testing to determine who is infected, and to have places where people who have the infection and do not require hospitalization. These settings can either be cohorted, meaning once you know that people have the infection, there are some reasons why in some situations it might be safer to actually group them with other people who have the infection, or to put them in an individual room in hotels. But it's important to keep those who have the infection away from those who either might have the infection or don't have the infection. When you do this, when you have these dedicated places, you will decrease stress on hospitals at the same time as protecting others in congregate settings. And I emphasize the decreased stress on hospitals both because it's an important thing to do, but also because I want to point out that that is an important part of your advocacy, that taking these steps will not only protect many, many people from infection, it will also decrease strain on healthcare settings. By prioritizing those at highest risk for complications who remain uninfected, this is going to decrease the likelihood of hospitalizations and mortality, with the idea that were people to become infected, we are trying to prioritize those who would be least able to weather the infection and placing them preventively in these special isolated resources like hotels and motels. However, it goes without saying that as resources expand, one could lower their threshold to put people in hotels. If we had enough hotel rooms for everyone who was homeless, we would certainly recommend that. We are just going under the assumption that we might not, and giving you a framework for how to prioritize their use. Next slide. Cynthia, back to you.
So now we're going to talk about, get into sort of the critical elements of the recommended protocols. Again, I ask you to refer to the actual document called Protocols in your handouts there, and we will walk through some of the high level stuff just to make sure you kind of understand the context and the sort of the kind of how these came together and some of the thinking behind it. So I want to just again say that the recommended protocols here were developed in partnership for the state of California with local, state, and federal experts, as I said before, in partnership with Dr. Margot Kuchel and the UCSF BHHI. We are you know, everything that is in the protocols are aligned with the most recent CDC guidance and emerging lessons. They, you know, as lessons sort of emerge, we will potentially, that the state might update them. But I want to point out that these were informed also by the experience and guidance of frontline service providers as quickly as we could get that information, and home system leaders from across the state. And we really want to say thank you to those folks. Other point I want to make is that coordination is really essential. These recommendations will work best if managed and filtered through a centralized, coordinated system with your local or county public health department, emergency services office, and local continuum of care and homeless providers. We know that this coordination may not have existed before, may sort of, you might have some partnerships, but sort of strengthening this coordination is really pretty critical to these protocols really flowing as they are intended. There are several definitions in the document that is in your handouts. However, we just wanted to highlight a few that we will be sort of repeating today. COVID positive, that's pretty obvious. It's an individual that has tested positive for COVID-19. And this will include people who are confirmed COVID positive but do not require hospitalization at this point, and people who have completed hospital stays and no longer require hospitalization but who are still potentially infectious. Person under investigation, PUI, medical term for an individual with positive symptom screen, or if possible, a positive secondary screen. And that means that an RN or another medical professional, as referred to by your outreach or shelter staff, has screened the individual and considers the individual at high risk of infection. And then there's presumed COVID-19 negative. So not COVID positive or not a person under investigation. These individuals are currently not showing symptoms, but may still be or could become COVID positive. As I said, there's more definitions included in the protocol, and you can ask questions to if you need some help kind of figuring out what those mean. So some critical elements to contextualize the screening and referral protocols. First, focus intensive infection prevention efforts on those most likely to develop severe complications from COVID-19, including both people who are currently in shelters and people who are currently unsheltered. And that kind of goes back to the principles, the guiding principles that Margot opened up with, kind of why it's important to focus your most intensive infection prevention efforts on those folks. So that might mean expanding the category of those receiving intensive infection prevention efforts if resources permit. We know that might not always be available, and that the primary strategy, ideally for intensive infection prevention efforts, is providing single occupancy housing. So hotels, motels, trailers, wherever you can give people individual units where they have private bathrooms and are able to stay somewhat quarantined. So second, reduce risk for people in shelters and congregate settings through decreasing the density of people staying there. And this may require creating additional or auxiliary spaces to sustain bed numbers, right? So we don't want to decrease bed capacity, but we need to figure out how to give people the space in shelters to have social distancing and be able to increase cleaning and screening guests for symptoms. Vivian will talk a little bit about how they're doing that in their shelters as well. Separate people with symptoms quickly and ensure they wear face masks. So you want to create isolation units. Again, that might be hotels, motels. We're doing trailers in California for people under investigation or PUI. Cohort COVID positive individuals in group settings. Margot touched on this a little bit, and I think she'll talk about it a little bit more. With appropriate healthcare personnel, or place COVID positive people in individual isolation units for the duration of the quarantine. The flow chart that we will show you later will kind of help you sort of visualize this so that it kind of makes it clear kind of who is recommended to go where. Number 5, prioritize individual housing units for unsheltered and sheltered individuals experiencing homelessness who are either people under investigation, PUI, or at high risk of medical complications defined in the written protocols. Again, that's sort of going back to the principles that Margot mentioned in the beginning about trying to really kind of reduce put sort of the most intensive interventions that we have to keep people safe for the people who are most at risk. I want to note something here just before we go into this element number 6. Communities should make every effort to bring people who are living outside indoors to either individual units or settings where recommended social distancing and cleaning and screening procedures are available. So we want to say that from the outset. If these options are not available, the CDC has recommended that communities should not be clearing encampments and dispersing people throughout the community. As I mentioned earlier, it's important to therefore, sort of not say, well, okay, people in encampments are fine, because often they are not really living in conditions that are conducive to being able to follow these guidelines. So if people living outside are asymptomatic, do provide outreach services, that's screening, food, hygiene, and ensure that recommended social distancing is maintained in whatever ways you can where the individual is located, and really keep attempting to bring that person inside or those folks inside when appropriate spaces become available, right? So we don't want to just sort of let people be outside because the CDC recommendation says that it's okay not to sweep encampments. We want to make sure that we're still thinking about those folks and trying to make sure that they're not vulnerable and adhering to these guidelines as best as they can. I'm going to hand it back to Dr. Margaret Koschel to talk about screening and referral protocols.
Great, thank you, Cynthia. Next slide. So in order to do the screening and referral, it's important to be able to first to think about being able to screen people for symptoms of COVID. I want to point out that there's no question that it's possible that asymptomatic people could in fact be infected and pass on the infection. But in this setting, what we are talking about is screening for symptoms that may be suggestive of infection. To a certain extent, localities might want to adapt these screening questions, but I'm giving you these questions or ways to do screening that have been used by several settings and are recommended by the CDC. These are screenings that can be done by shelter clients or homeless outreach staff to ask the individual, do they have a cough? Some places like Boston, noting that many people experiencing homelessness have coughs at baseline, might ask things like, do you have a cough that has changed? Are you feeling feverish? And are you having difficulty breathing, or is it worse than it usually is? And then the other component of screening that is important is to take temperatures. Generally, we are using cutoffs of a temperature, a Fahrenheit temperature of 100.4 to consider someone positive. In some places, they are using the first questions to decide who gets their temperature taken, and then referring someone who has a positive answer to those questions and a temperature. Others are using any of the above. These questions should be asked at least daily in shelter settings and as often as possible by outreach workers. Next slide, please. This is our triage protocol, which I know looks messy. I'm going to try to walk you through it. I just want to note that on the left side of the chart, it acknowledges that there will be people who are identified in medical facilities who will then, it's very important that those medical facilities, A, are screening to know when people who they're screening are houseless or homeless, so that they are not sent back to congregate settings, and that those individuals who are potentially infectious or infectious will go down the same protocol starting at step 2. They would have a place to go. But I'm going to concentrate on my remarks on what we should do for sheltered and unsheltered homeless clients being screened for by staff. Next slide. So in a shelter or unsheltered setting, we talked about these basic screening checked done by shelter outreach staff. If an individual answers yes to triage questions and or has a fever, we recommend that there be another level of observation. At that point, as soon as someone screens yes, they should be offered a mask and given a place to stay, have a pre-identified place in the shelter that is away from others. Then they should be referred either by phone or through some or sent to transported to a place where they can be further examined to see if they meet the criteria for being what we call a person under investigation. That at that point the person would receive a test for COVID. We are then recommending that people be sorted if they do not screen positive. If people do not have those symptoms, they should be assessed of whether they are someone who has what we are calling a high risk for complications. These would be defined by age, people 60 and over, or people with an underlying medical conditions. These conditions include things like chronic obstructive pulmonary disease or asthma, heart disease, cancer, diabetes, end-stage renal disease. These would be the type of illnesses that place one at high risk of complications, versus someone who both screens negative and does not fall into those risk categories by virtue of younger age or not having those comorbid illnesses. Next slide. For the people who are screened to be a person under investigation or are known to be COVID infected. They can be sent to places for isolation and further testing. We are recommending that if people are known to be infected and are frail and thus might be unable to self-manage in a motel or need closer observation of healthcare staff, one option is send them to an alternative care setting. These are places like shelters that have been repurposed with medical personnel who are wearing PPE, who can care for the individuals in a place that is less resource intense than a hospital, but has some medical personnel with eyes on the person at all times. If they are COVID infected, or if they are a person under investigation, no matter what, if they have not been confirmed, they should be sent to some place where they can be completely isolated. These can be motels, hotels, trailers, where the person can be placed in isolation. And I will defer to my colleague Vivian Wong to discuss exactly how they operationalize these settings. If someone is screened to be presumed COVID negative, and they had a high risk of complications, they should be referred for isolation, a place like a hotel or a motel. Ideally, one would use a separate hotel or motel for the people who are under investigation and infected from the place where you would send people who are presumed not to have COVID, but who we were trying to place in a higher degree of isolation in our best effort to prevent them from becoming infected. If people went through this screening and were not shown to have signs or symptoms suggesting COVID infection, and they were at low risk for complications, if they were in shelter, we would recommend that they stay in shelter in their current status, and this assumes that the shelters can meet distancing protocols. If they were unsheltered, ideally they would be offered a sheltered location that met distancing protocols. If there were no such shelters open, we are recommending that if they cannot be offered a shelter that could keep them under distance, that they then would remain unsheltered if there were no other options. Next slide. For the unsheltered outreach staff, it really follows the same protocols. The basic checks done, the sorting people into 3 groups, potentially infected, in which case they need to be referred to an isolation facility where they can be tested or referred for healthcare for further evaluation, or if they screen negative and are at high risk of complications, to be referred to a hotel where they can be isolated from others and decrease their risk of spreading. And if they are low risk of complications, those are the individuals that we would recommend offering them shelter if there were shelter available, or otherwise leaving where they were. Next slide. And I think I have walked through the whole system. These guidance and protocols are available to you. So next slide. And I am turning it over to my wonderful colleague, Vivian Wong, the Chief Operating Officer of Abode Services, to talk about how they have actually stood up these shelters and hotels.
Thank you, Margot and Cynthia. Can you go to the next slide? It is frozen for me. Good. So again, my name's Vivian. I'm with Abode Services, and like I'm assuming many of you on this call, our mission is to end homelessness. Next slide. And we do that for a lot of folks every year, in the tune of about 12,000 over the past decade. And as Cynthia mentioned at the front end, we do a lot. Outreach, shelter, rapid rehousing, permanent supportive housing, and housing development. But today I'm going to really talk about our role on the outreach and shelter side of it all. Next slide, please. We serve the Bay Area region, so in 5 counties shown here, and again, serve about 10,000 folks a year. You can keep going. Next slide. So as I mentioned, we do a lot of different things, and I do want to say that in all communities we don't do exactly the same thing, and it's actually been really helpful that we don't do a ton of front door services in some of our communities, and I think that's something that's enabled us to actually really run with some of the new hotel operations that I'll talk about on the next slide. But staying here for a minute, I can't stress a few things enough. One is what Cynthia said in the onset: don't let the perfect get in the way of the good. That's been a huge mantra of mine, not only this, but in general. And the other thing I want to say is, I don't know about many of you, but it is just incredibly difficult to keep up with all of these resources that everyone keeps putting out, you know, and it's like well-meaning and great as they are, even from my esteemed colleagues from the Alliance and Margot, they're amazing, but sometimes there's not even enough hours in the day to read all of the resources, much less listen to the news. So at some point, you know, we have to take what we have, even though it's always changing, and go with it. So this is to say that we are trying things, and we are all sort of in this together, in that we are doing our best in imperfect circumstances. I work in some communities that have relatively few resources, and other higher resource, larger counties, and it looks really different. So I empathize with where everyone is, because we are there with you. It is hard to do this work, particularly when our workforce is challenged, because they're at home with kids and they're afraid as well. So first, I'm going to talk about what we've done to adapt some existing shelter outreach, you know, and really all programs. One of the things that we've done is, because we do all of these different things, is we have prioritized our front door and high need residential properties. So that means that, you know, there's a lot of us that normally are focused a lot on our scattered site housing and other things, but we've concentrated our hiring, our staffing. We've implemented some crisis pay for folks that are actually in our shelters, particularly our lowest paid staff who are shelter monitors. And then prioritize supplies going to those settings in which there cannot be as much at-home work done, where folks are more face-to-face with clients. We're doing what Margot and others around the country are suggesting, as we're trying to implement social distancing within our shelter, and we're trying to thin out our bed capacity. And that's not easy, not from a philosophical standpoint, when we know in the communities I work in, the vast majority of our folks are unsheltered. So for me to thin out a shelter, that means literally I have to close the door, right? I cannot be accepting new intakes as folks leave. Which is really philosophically hard, you know, and yet looking at the bigger picture, it is incredibly safe. It is incredibly important for us to keep those in the shelters safe. We've had to, you know, shut off the shelter to visitors, which means for us, all of our meal programs, we have a waiting list for a year for groups to come in and serve meals. So that's been a huge challenge on both the cost of those meals that we're having to incur, but also the cost to make those meals. This is to say, social distancing, we have thinned it out through some attrition, is one thing, and then as these other motels have started to lift off the ground, we've been able to place folks out of our shelter into those motel settings, prioritizing, again, those higher need folks by virtue of age or vulnerability by health status. Inside the shelters, as you know, as Margot mentioned, we are doing medical screenings, and I have to say this hasn't been as seamless as we had hoped. First, it's actually hard to actually get the thermometers that we need. We're all searching for the same supplies, and the thing I have to say here is partnership is key. It's really our healthcare service agencies in each respective counties, and all of your counties call it something different. It could be coming through your Office of Emergency Services, Health Department, Public Health, those are the agencies that are able to procure these supplies. And we found that you know, spinning our wheels looking for them ourselves was wasting our time and talent, where other folks could secure those for us, not as quickly as we want them, but eventually. So that's one hiccup. The other hiccup is once we have sort of the thermometers and set the policies and procedures in place, actually not only training staff to do it, but you know, training staff that even though this isn't really a typical scope of your job, it is important to do, and sort of reframing that for folks for the health and safety of everyone. Training staff, again, with evolving protocol and supplies. This has been a huge hurdle. Yesterday, or last night, I believe, in the state of California, it was announced that, well, maybe everyone should wear masks when we go outside. That's really hard when there's no masks available. So now it's you know, challenging to, again, keep up with all of the recommendations, and then the of course the lack of supplies to go along with that. So clearly communicating with all of our shelter staff to be as safe as possible. Of course, everyone, we're implementing the three things that everyone is trying to implement: social distancing, you know, wash your hands, all of that fun stuff. Other challenges with this, increased cleaning, you know, that we have implemented more cleaning daily, more than once a day in some of our shelters. But working that out, who will do it, because a lot of the cleaning agencies that we went to at first would not do it. We had to do a lot of begging and paying for that. And then who pays for it, going to our partners, our funders, to let them know on the front end, this is going to cost more, but we need to do that for the health and safety. Other things we've done is we've used we've looked at our use of spaces, and every shelter looks different. I totally get that, and every shelter is in a different place. So one of our shelters is sort of at the far end of the county, which is, you know, far away from sort of the center of that county. So even if these isolation hotels come available, it is unlikely that our folks will go, because they view it as the other side of the world. So we are looking at ways to reconfigure our offices, our conference rooms, and also our family rooms, potentially putting some families in motels to free up those family rooms that have contained bathrooms, and they're more contained settings. So this is just to say that things that you never thought you could do because of a conditional use permit or a regulatory agreement, all of that sort of goes out the window, and you know, we've just had to look at our shelters just with completely fresh eyes. Next slide, please. And then on top of sort of the normal maintaining what you already do, and a workforce that is constrained and scared of lots of things. Ooh, keeps going back and forth. We're doing a few new things. One is just acknowledging that each county is different. And, you know, each has the Office of Emergency Services, deals with supplies differently, has different health resources. And in our community, we have different roles in each one of those counties. So how you access all of this is really happening in different ways everywhere we're at. So we are operating new sites, you know, and again, we're at the front end still, so you know, it'll probably be 5 to 8 new sites by the end of it. A few considerations for all of them for us have been roles, you know, in that we need healthcare at the table. If folks want us to do more, our first question is, what is the healthcare component? This is a health crisis, and we're a homeless service providing agency. And I've always talked about the intersection between health and homelessness, and it's never been so apparent as it is right now. However, we are not trained docs, we are not trained nurses, we need those partners. I'm always asking, when folks are coming to us, What are we talking about here? Are we talking about prioritization of the COVID positive folks or the presumptive or the people under investigation? Or are we looking at the vulnerable side? Because that needs to be staffed in very different ways with different PPE. Again, that medical piece, medical screening and entry. What are the staffing levels? You know, are we talking about 24/7 staffing or overnight or weekends, that sort of thing from an operational standpoints? All of you that you run shelters know that this is easier said than done, getting folks to work weekends, after hours, you know, everywhere we're at. PPE, this is huge, both in what people think that they need, what we think that they need, and what each respective health department says that they need, and how much of that is constricted by their supply. So this is a negotiation, you know, process, but this has been a huge learning for us, working with medical professionals and having to train ourselves and our staff about N95. It's not only having those that PPE, but really knowing how to use it, because we don't want to really throw valuable resources down the drain, making sure that training is available. The other consideration, of course, is harm reduction and isolation. I've been running shelter for a long time, and we always say that we are a harm reduction agency. However, in our shelter, you know, we don't allow folks to, you know, drink and actively use in our shelter. You know, we talk about ways that they can live peacefully, and we, of course, don't exit folks if they're under the influence. But in an isolation setting, particularly for a hotel that is dedicated for folks that are people under investigation or COVID positive, we need to look at harm reduction in a different way. If they cannot go off site to meet their needs, how are those needs met in a safe way that doesn't further risk their health? Next slide, please. Very specifically, want to talk about our effort in Oakland in lifting up 2 shelters, Operation Comfort and Safer Ground. And again, cannot stress partnership enough. We do not do this alone. The state of California is a huge partner. We actually contract directly with them. But Alameda County, when I say Alameda County, I mean all parts. Alameda County is a fairly large county, and there are several different departments: healthcare service agency, social service agency, general assistance. Like, all of those parts are working really closely together with us, along with other partners, to lift this off the ground. And what this looks like is it's 2 hotels with almost 400 rooms, one specifically for folks who are COVID positive. The other one is for folks that are just vulnerable, that we're trying to isolate. Staffing, you know, we're looking at about 36 FTE through Abode only. And let me stress that there are a lot of medical staff on site and dedicated to these efforts that are beyond Abode. What's interesting is we've had to hire most of these staff because, again, we are already constrained, and this is sort of the silver lining. We sent out this job posting and received over 220 applicants in a matter of days, being very clear on what it was. So I think there's a huge desire for folks to help. We were thoughtful around training plan, lifting up videos of the on-site training as quickly as the trainings occurred. We just had our training coordinator come and do videos so that as new staff came on board or overnight staff needed to be trained, that was easy to do. We created cheat sheets, not only for our staff, but for the hotel staff and for security and transportation staff. And I mean cheat sheets like, what is homelessness? What is, you know, just the basics of the program? What are the root causes of homelessness? That sort of thing. That's our bread and butter that we have 101 acronyms for, but other folks might not understand. And then we have an online training platform that we pulled off our 12 highest, what we thought were the bare bones basic to train staff really quickly. from, de-escalation techniques and that sort of thing, so that staff could be trained. Our staffing is 24/7 with shelter monitor type staff, and then we also have community health workers and housing navigators. It's really important to me to think about the exit plan at the minute folks enter, particularly for the site that has vulnerable folks, that their length of stay is likely to be longer. There's other supports in place. Food is provided by the hotel through the state contract. Transportation was secured through the county. So we have vehicles going to pick folks up in the referral, as the referrals come in. And there was a lot of thoughtful design on making sure those vehicles were practicing the safety precautions that they needed to. And then, of course, security as well. These are some pretty large hotels, and we wanted to make sure that there were eyes on all the entrances. So we developed a ramp-up plan, and we are by no means an expert here. We are probably a few days or maybe a week ahead of some of all of you, or some or all of you. But this has moved. I've been in this field for more than 20 years, and this has moved faster than anything I've ever seen. We were called by the state on Thursday afternoon. By that Sunday, I was in contract with the state, and by Wednesday, we had moved in our first guest into the building. So this was not done with 8-hour days. That the entire team, Abode, the county, others were working 18 to 20-hour days to make that happen. But I can say that none of us were ready when we admitted that first person. I say this because that we have to start before we have every policy and procedure nailed out absolutely to the T. It was really important for us to test some of these practices out and then modify after. So we started with the basics in terms of, okay, health and safety. How do we get folks from point A to point B? What's our referral mechanism? How do we ensure that our guests is safe and the staff that are assisting them are safe? And then everything else we worked on creating as we went. So that's just a reflection for all of you planners, and it is going to be crazy uncomfortable to launch without everything in place. We took into consideration the movement in hotels. We allow each household to bring a pet. We acknowledge that folks are smokers, so we have a schedule set up for each small block of hotel rooms to go walk their pets into smoke in a way that they can't congregate. We've decided for the hotel that is for COVID positive folks that we will not be giving out room keys, so that we can, again, make sure that people aren't going in and out or in each other's rooms or sharing that key. We're trying to address isolation challenges. So isolation for all of us is really anxiety provoking, but for our folks, it can be particularly challenging. So, trying to do a lot of telephonic stuff, trying to connect them to their informal networks through telephone, trying to keep them busy with puzzles and games and whatever they'll do inside those units. We've had to think through expectations, so participant agreements, and really that's been a huge learning, because the first few referrals that have come in, the referring agencies weren't super clear on what these hotels were. So that meant the guest wasn't super clear. So folks wanted to come in and out a lot. So we've gotten clearer with the referral agencies in that process. We've had to think through, what if someone leaves before they're medically clear to leave? What sort of notifications need to happen? This is really testing, our philosophy. I mean, our folks are guests, right? They're adults. If they leave, this is not a lockdown facility. So we are doing everything that we can to encourage them to stay, but we have protocols in place if they do leave. I mentioned harm reduction in terms of thinking through, both from the medical perspective, what can be provided and offered to reduce the detoxing that might occur for those that are using substances. But we've made the decision to actually supply alcohol in a medical plan, so that we're encouraging folks to stay, and there's also, as Margot can attest to, really significant health concerns that folks, can die if they go off of alcohol, in a cold turkey way, depending on their substance abuse. Medical supports, as I mentioned, training and security, training for security, transportation, and hotel. Oh my gosh, media inquiries. I'm sure that you can commiserate with me that as we're trying to lift this up, the media is sometimes a friend and sometimes very critical on, hey, why aren't you doing this faster? And wanting to talk to us at every moment. So we were really clear on who is the media contact, one contact for the entire team, and that's the county sort of PIO, which has been tremendously helpful. And then of course, and not last, I don't know why this is last, but really thinking through the safety, for staff, the agency, and community through PPE, through waivers, and through sort of managing the flow of the program. I just said what was probably 500 hours of planning and like 20 minutes went over my time, but I think that is it. Passing it back.
Thank you, Vivian. Everyone, you'll see here contact information, and again, these slides will be available to you, so you can contact any of our great presenters after the webinar. Now we just want to get started on the Q&A. Thank you so much to all our California partners. Hang on just a minute. Okay. I know Christy has been taking a lot of questions, so we're going to go ahead and get started with the Q&A portion of the webinar. As a reminder to all attendees, while we have many more questions to get to than we have time remaining on the webinar, the Alliance is gathering all the questions and responding to as many of them as possible in upcoming webinars via other resources. We are also putting together a listserv where experts like those on our webinar today will be able to respond to questions that you have, and you'll all be able to share with one another what's going on in your communities, innovations, challenges that you're struggling with. So look for that. In the meantime, first question, I'm going to unmute, or actually, if you could all unmute yourselves. Okay. First question, Cynthia, is for you, and this is more about system level thinking as communities are trying to address the intersection of COVID-19 and homelessness and to implement similar protocols. You talked a lot about the need for coordination. Do you recommend using coordinated entry, existing coordinated entry systems to screen and refer people for isolation rooms?
So this is a great question and a complicated one, and I actually think probably Margot and Vivian will probably have some thoughts on this as well. I mean, I think that, and I know you all are going to have I think a webinar on this kind of thinking in I think a couple of weeks, but I think that at this point it's really, I mean, coordinated entry is sort of, really the ideal way it's going to work is to match people to housing as quickly as possible. Most systems in most communities don't have coordinated connected to their emergency kind of services, to their crisis system, to their shelter. Some do, some don't. And what coordinated entry is prioritizing for may be quite different than what we're talking about prioritizing for here. So Vivian talked a little bit how they're using coordinated entry in some kind of integrating some aspects of coordinated entry, and I'll let her kind of talk a little bit more about that. So I think you have to kind of only use it for what makes sense, because who might be vulnerable high up in your coordinated entry list may not match who is, kind of vulnerable in the ways that we're talking about here in terms of, you know, being vulnerable to infection, to being hospitalized. And so I think you have to be really careful. You don't want to completely skirt your coordinated entry system for housing. Perhaps there are people who are going into these units or into shelter who are already high up on the coordinated entry list, and they should continue to be people, you know, the community providers that work to house people should continue to try to, you know, provide housing to those people who are high up on the list. Hopefully it'll be easier if some of those people are bought indoors now to help house them. I know Vivian talked a little bit about having housing navigators in these hotels, so they're going to continue to house people. They're rapid rehousing permanent supportive housing providers, that they're also still continuing to house people. So I think you have to be really careful in thinking through that. I wouldn't just switch to using coordinated entry to prioritize, though. I think you'd have to be really thoughtful in how you might want to take some parts of it to continue to house people. But really the prioritization looks different to me. That's just my thoughts. I don't know, Vivian, Margot, do you have thoughts on this?
This is Vivian. I think you said it well. You know, one of the things that we are struggling with as we launch these 2 hotels in Oakland is that very question. And the other balance is, you know, some of our coordinated entry systems aren't, they're not getting people indoors quick enough, right? So if the coordinated entry system, if we're identifying a specific person and not filling that room, that's also a problem. So we're balancing wanting to really get as many vulnerable people inside as quickly as we can with that belief that coordinated entry systems really work, right? So that it's a real balance, and I think a purist approach will not work here.
Great, thank you. Margot, did you have some thoughts?
Oh, I mean, I would agree with what both Vivian and Cynthia said, you know, if you're doing in a crisis, sometimes we need to adapt. And if you're doing age-based cutoffs and you are looking at a population with large number of people who are unsheltered, who may not have had the opportunity to enter the coordinated entry system, and they meet, for instance, your age criteria, it seems like it would make sense to bring them in and perhaps enroll them in coordinated entry, or do the coordinated entry as you're enrolling, you know, as they're coming indoors.
Great, thank you. Margot, I have a question specifically for you. A lot of folks had very, very much the healthcare medical related questions. And you and Cynthia both talked about, and Vivian too, like we are not in an ideal situation. Protocols necessarily are drafted for what will be an ideal situation, and then we have to be able to adapt at the local level depending on the context. So how about implementing these protocols when you don't have, at the shelter staff level, you don't have masks, you don't have PPE, very few folks are in the ideal situation. So what are the recommendations there?
Right. I think that's a great question. In a world where even healthcare providers are lacking PPE, obviously we're far from ideal. I think my comment about where PPE, full protection, was clearly needed was if you have a facility where everyone is known to be infected. That goes without saying. I think for other facilities, the recommendations are changing day by day. You know, regular masks like surgical masks, or even just covering someone with using even a bandana or something, it's far from ideal. But in some ways, you're better off using those resources on people who are coughing, because they do a better job of protecting people from spreading infection than they certainly something like a you know, a face covering can help prevent people from spreading infection. I would say that if you have shelter staff or workers who are in the group who are particularly vulnerable to having severe consequences, you may want to ask them not to be the ones doing you know, the face-to-face work, let's say, with people who are coughing or otherwise. I do think this is a moving target. I think it's very possible, and you know, LA County has just asked everybody to mask. I think we might see that as a recommendation. Just to be clear, those recommendations are generally to keep people from spreading infection rather than people from acquiring infection. As Vivian noted, the N95 masks are masks that, for instance, healthcare providers, we get fitted every year. It takes about an hour of testing to make sure that they're using them properly. And they are to protect against aerosolized material. So certain infections like tuberculosis, they're important in, or we are in healthcare settings prioritizing those for people who are doing procedures or otherwise. Even in healthcare settings, we are mostly relying on plain surgical masks. So what I would say is, you know, these protocols were put in place to protect people as much as possible. In Vivian's hotel, where everyone is either a person under investigation or known to be positive, those are places where you really, really do want to, as best you can, use PPE. You know, in a regular shelter setting, I think it's a little bit, it would be ideal, but it's perhaps less absolutely essential. But what is essential is if someone does display any symptoms, that they have a mask put on them right away. And I think we might get to the point where there might be recommendations for people in public settings and in places like shelters just to wear masks at all times, with the understanding, though, that that is mainly being done to protect people from spreading the infection.
Great, thank you. I have a question. I think I would like to start. There were several questions that are related to something that you raised, Vivian, about how these public health responses can bump up against what has been a pretty firmly developed philosophy in the homelessness field about housing first and client autonomy, in referring to folks as guests, you know, and not being in lockdown situations. So we have questions about stay-at-home orders and shelters. How are you, enforcing stay-at-home orders for folks who are in shelters, especially thinking about folks who may have mental health issues that make it more difficult for them to understand even like what's going on here and what a stay-at-home order means and what the reasoning for that is. So Vivian, I'd like to start with you. I think you're definitely having to deal with that on the ground. And then also Cynthia and Margot, if you could kind of talk about that, that intersection between the public health philosophy and the traditional homelessness housing first philosophy in developing these protocols. Go ahead, Vivian.
Yeah, no, it's hard, and there's nothing nothing easy, about it, other than to say that the stay-at-home orders sort of still treat folks like adults, right? You know, if my husband needs to go to the store to get something for me, he goes. That's allowed. So the same is true for our guests, clients, residents, whatever you might call the folks that live in your shelters. So there's sort of enormous responsibility that we feel both for the folks that we serve and for the greater community. But just reminding ourselves that folks have their own autonomy and we are not the police. That being said, in our Oakland hotels, we, Abode, the county, others, we are coordinating with the police department so that they know what's going on there, and so that we know that we can call on them, because as all of you know that work in this setting, that social workers are miracle workers. They're exceptional de-escalators, and still sometimes we have to call upon police to help us out in crisis situations. So again, it's that partnership piece of us not becoming the police, us not locking people in, but and then just utilizing our best skills to talk to people, communicate where they're at, to encourage them to stay indoors. I don't know if that answers the question specifically. There's no perfect answers, other than I'm always in awe of my staff on the ground who do this day in and day out.
Great. Thanks.
Yeah.
Margot and Cynthia, since both of you have been working in the homelessness field for so long, just also addressing that issue of now there's this public health crisis and the differing philosophies of the two, especially as you were developing these protocols.
Sure, I can respond a little bit. I think Vivian captured the extreme challenge of thinking through this, because it's something that, you know, we're sort of having to think through on the fly. There's ethical questions. There's, you know, kind of thinking about what happens when you have to refuse services to somebody. That always should be a consideration, but now it's even sort of more pressure on trying to make sure that that person is still safe. I think in this instance, you know, you're trying to balance the health and safety, and sometimes that's going to supersede people's ability to just do kind of the same activities that they were doing before, that's true for all of us, within reason. So, for example, we've been getting questions about, well, what if someone refuses a medical screening, you know, when they're in shelter? Well, in general, when we recommend, you know, what low barrier shelter looks like, it's not sort of anyone can do anything that they want. It's really we're asking people to try. We're trying to meet people's needs. We're trying to be as accommodating as we can. But when someone is endangering themselves or the health and safety of others, we do consider trying to figure out ways for them to either, you know, to engage that person, to you know, agree or comply, or find alternative places for them where they're not going to be endangering others. So I think some of those things we just have to keep thinking about, balancing the health and safety needs of the person versus the environment, and then do our best to sort of find the ways, if people aren't able to comply, to figure out where else we can keep them. If they're going to have to be unsheltered because they don't want to come inside, or they don't want to, you know, sort of align with some of the things that are happening in shelter, even in a very low barrier harm reduction environment, that we are still thinking about their safety and making sure they're able to go back to a place that at least they have some ability to stay safe. But I think that just balancing that, trying to keep health and safety, and sometimes in this situation you have to sort of have that supersede some of the more traditional ways we would think about keeping, you know, sort of low barrier access available. And I don't want that to mean like we roll back all of our low barrier access. We just have to think about something superseding what we would normally do.
Thank you, Cynthia. Margot, do you want to comment on?
Yeah, I might also make a distinction between people who are known to be infected from the others, and local policy and local health departments and local infection control may provide guidance on different levels, you know, for people known to be infected than others. But I think, you know, what I see Vivian's group doing and others' group doing are really Herculean efforts, particularly for people who we really need to stay indoors, to use harm reduction philosophies to change the way perhaps that we've been doing things in order to meet those dual goals of, you know, respecting the patient's autonomy while keeping them and others safe. So I think for, in a sense, for folks, it feels like it's a slightly different issue for folks with known infection, and their local health departments may have different guidance on you know, on what they recommend and what to do. But I think for all really escalating our harm reduction in terms of, you know, particularly folks with substance use disorders or others who might need extra supports or accommodations in order to stay, seems like a really high priority.
Yeah, I want to just underscore that. It's such an important point. I think actually what we might, one very small silver lining, is we might learn how to provide harm reduction services in a way that we're being pushed to do and we're sort of never able or allowed or funded to do before, like bringing alcohol management to people into their on-site, you know, where they are, instead of trying to help them manage that outside of the sites where we usually do. And I think we could learn a lot from that. I think there's a lot that we can do to change how we do harm reduction in a positive way, because we are now trying to accommodate people's needs in a very direct, different way.
Great. Thank you, Cynthia. And thank you all so much. And I love that we're ending on that note of a silver lining. I think there are many, and I think right now we're so deeply in crisis, it's hard to hold on to that. And what a better one to come from this than increasing harm reduction and housing first philosophies. Okay, so we are a little bit over time. Thanks y'all for hanging with us and for all your great questions. I do want to thank all of our incredible partners for this webinar and for your leadership on this issue in the state of California and nationally. I do want to give you all a final reminder about our upcoming webinars. Again, because of the overwhelming demand on registration, after today's webinar, we're going to be shifting to a different webinar platform, Zoom, that will accommodate many more users and ensure that all of you are able to access our COVID-19 webinar content in real time. So the links that you see on this slide and these slides will be available after the webinar. And on the Alliance's events page are updated to this new platform, so you can go in there. Again, for those of you who had previously registered on the old link, your registration was automatically transferred to the new platform, and you'll be resent some confirmation emails to ensure that you have access to that new link. Thank you again for all of your profound dedication and persistence to serving people experiencing homelessness during this pandemic. You really are superheroes. We at the Alliance see you and appreciate you and want to make sure that you have all the information you need to improve the COVID-19 response in your programs and communities. And we will continue to try to be a resource for you during this crisis. Just to let you know, be on the lookout for our development of a community listserv where experts like those on our webinar today can answer questions and where you all can share information with one another about things that are going on in your community and how you're meeting the challenges and innovating to respond to the coronavirus pandemic. So don't hesitate to reach out to us, and we'll see you all on next week's webinars. Thank you.